Good morning. Here we are coming to the hematopoietic and lymphoid module pathology. We will cover in this module the most important topics in the hematopathology, including the definition of hematopoiesis, what is the reticulocytes, what is anemia mean, the types of anemia, including hemolytic anemia, what is the meaning of hemolytic anemia, what is intravascular hemolysis, what is the difference between intravascular hemolysis and extravascular hemolysis. Then we are coming to the types of the anemia, including spherocytosis, hemoglobinopathies, sickle cell anemia, thalassemia, types of the thalassemia. Then we go through the other types of the anemia, like autoimmune hemolytic anemia, paroxysmal nocturnal hemoglobinuria, what else? Megaloblastic anemia, iron deficiency anemia, and then we will cover we finish all the topics regarding the red blood cell disorder, and then go through the topics that concerning the white blood cell disorder, including leukopenia, leukocytosis, basophilia, eosinophilia, and then we are coming to the important topic, the tumors of the bone marrow, the blood malignancy, including leukemias. The type of the leukemias that we will cover: acute lymphoblastic leukemia, chronic lymphoblastic or lymphocytic leukemia, acute myeloid leukemia, and chronic myeloid leukemia. All of these, the neoplastic proliferation of blood cell or of lymphocyte or other type of white blood cell, will be covered according to the age, according to the prevalence, the incidence, the types, and the images or the peripheral blood film or the bone marrow aspirate pictures will be included within this pathology or within this module. At the same time, we will cover also the homeostasis. What is the homeostasis? Bleeding disorder, thrombocytopenia, when there is decrease in the number of the platelet, the causes of the decrease of the number of the platelet, the other things that we will cover: splenomegaly, hypersplenism. All these topics regarding the blood disease will be covered in these lectures, and also it will be followed by the malignant lymphomas, including Hodgkin lymphomas and non-Hodgkin lymphomas, and the malignancy of the plasma cell. All of these topics will be included within the hematopoietic and lymphoid module pathology. Hematopoiesis. What is the meaning of hematopoiesis? It is the production of all types of the blood cells, including formation, development, and differentiation of the blood cells. What are blood cells? Blood cells including the white blood cells, red blood cells, and platelet. In the embryo prenatally, the hematopoiesis occurs in the yolk sac, then in the liver, and lastly in the bone marrow. In the normal situation, hematopoiesis in the adult occurs in the bone marrow and lymphatic tissue. All types of the blood cells are derived from primitive cells, which are the mother cells, the stem cells that are pluripotential stem cells that have the capacity and capability to develop into different types of the blood cell. Introduction. The hematopoietic lymphoid systems are affected by the wide spectrum of diseases. The primary hematopoietic disorder most commonly encountered are the red blood cell disorder which manifested by anemia, while the white blood cell disorder most often manifested by proliferation. The proliferation might be reactive, benign, or might be neoplastics as in the leukemias. Hemostatic derangement. What is the meaning of the hemostatic derangement? When there's abnormal in the coagulation system, abnormal in the coagulative cascade, patient has bleeding tendency. This is a hemorrhagic diathesis. Finally, splenomegaly is a later manifestation of the blood disease. The lymphoid system disorders refer to the diseases that affect the B or T lymphocytes, whether it is inflammatory or a neoplastic condition. In the inflammatory condition or reactive condition, such as in the lymphadenitis when there is painful lymph nodes in the cervical region, such as in the case of the tonsillitis or in the case of pharyngitis, associated with the painful enlargement of the painful enlargement of the lymph node in the cervical region. So the lymph nodes are tender when try to examine it or touch it. While in the lymph, and there are certain viral infection that is associated also with generalized enlargement of the lymph nodes, whether associated with the painful lymph nodes or unpainful lymph nodes, such as in the toxoplasmosis or the infectious mononucleosis. There are many reactive inflammatory condition that is associated with the inflammatory condition of the lymphadenitis. While in the lymphoma, it is a neoplastic condition. It is associated with the neoplastic proliferation of the lymphocyte inside the lymph nodes, also might involve the spleen or the liver or the bone marrow. All of these will be discussed thoroughly in the last lectures of the pathology in this system. There is a close linkage in between both system, hematopoietic and the lymphoid. What does that mean? The pathogenic derangement of one cell type of the system might affect the other cell type, such as when the B lymphocyte sometimes it produces autoantibody. In some cases of thrombocytopenia, in which there is decrease the amount of the number of the platelet in the blood, the platelet, the count of the platelet in the blood is decreased in thrombocytopenia. Why this is decreased? In certain cases of the maybe due to the autoimmune reaction, maybe due to the it is maybe preceded by the viral infection induced production of the autoantibody from the lymph node to attack the platelet and cause thrombocytopenia, or sometimes against red blood cell membrane, as in some types of the hemolytic anemia, as in the case of the autoimmune hemolytic anemia. Also, in certain cases of the leukemia, which is a neoplastic proliferation of the blood cell in the bone marrow, we see the blood cell in the blood. We will discuss this topic thoroughly in the lecture also. At the terminal stages of the disease, leukemic white blood cell can be accumulate where in the many tissue in various tissue of the body, in the various organs, including the lymph nodes, which cause lymphadenopathy. Sometimes it simulates lymphoma, sometimes misdiagnosed as lymphoma. However, the disease is different. It's different because it is a leukemia. While in the terminal stages of the lymphoma, malignant lymphocytic cells sometimes may be accumulated in the bone marrow or might be seen in the peripheral blood, which simulate leukemia. Those are the conditions that correlate with each other, and so it confirms that there is close linkage in between both hematopoietic and lymphoid system. In these lectures, we will discuss the disorders of the red blood cells, classification of anemia, the types of anemia, the cause of anemia, hemolytic anemias. We will get through these topics thoroughly, whether the hemolysis due to it is intravascular hemolysis, then what is the intravascular hemolysis, what is the extravascular hemolysis, what is the difference between the two, يعني تكسر كريات الدم الحمر inside the blood circulation. It is intravascular hemolysis. Extravascular hemolysis تكسر كريات الدم الحمر outside the circulation. when يعني outside the circulation in the liver and in the spleen. And each one of these has different presentation, different laboratory investigation, and also we will discuss hereditary spherocytosis. Now we are discussing anemia. What is the anemia? Anemia is a reduction in the oxygen transporting capacity of the blood. That means the oxygen transporting capacity of the blood reduce that it will lead to the reduction of the total circulating red blood cell mass to below normal level. Hemoglobin normally is below 13.5 gram per deciliter in the male and 12.5 gram per deciliter in the female. The anemia can be result from the excessive bleeding, increased red blood cell destruction, decrease in the red blood cell. Classification of anemia according to the underlying mechanism. First, blood loss, acute or chronic blood loss. Acute blood loss, as in the case of the trauma, or in the case of the bleeding hemorrhage. Accident, as example, an accident, or as example of rupture aneurysm of the aorta in the abdominal cavity, or in the and so it will lead to the internal bleeding that lead to the acute blood loss. Or there is a chronic blood loss, as in the GI tract bleeding, as in the peptic ulcer, or gynecologic causes, as in the cases of the menstrual bleeding, or metrorrhagia or amenorrhagia, especially around in the perimenopausal female. In the case of the increased destruction of red blood cell, as in the case of the hemolytic anemia, this is in the case of the hemolytic anemia, it is intrinsic intracorpuscular abnormalities, maybe hereditary. In case of hereditary, when there is membrane abnormalities in the cell membrane, as in the cases of spherocytosis or elliptocytosis or a beta lipoproteinemia, or in the cases when there is enzyme deficiency, especially in the G6PD deficiency. Therefore, any newborn baby should examined and should be tested postnatally by G6PD, which is one of the neonatal tests that should be done for every neonates. Or there is disorder of the hemoglobin synthesis, as in the hemoglobinopathies, when there is deficient in the globin synthesis, as in the thalassemia, or when there is structurally abnormal in the globin synthesis, when there is replacement or the substitution of the certain amino acid replaced by the other amino acid, as in the case of sickle cell anemia. Or acquired cases, as in the membrane defect, as in the paroxysmal nocturnal hemoglobinuria, or there is extrinsic extracorpuscular abnormalities and antibody mediated, as in the isohemagglutinin, especially in the transfusion reaction, in case of the Rh disease mismatching, or in the ABO incompatibility, or in the erythroblastosis fetalis, in which there is mismatching between the blood of the baby and the blood of the mother, when there is especially in Rh negative mother, and this is usually happened especially in the second baby, because of the first baby, if the mother is Rh negative and the baby is Rh positive, the blood of the mother will transfer into the the blood of the baby transfer to the mother. It will lead to the production or stimulate the mother to produce autoantibody. So in the second baby, if the blood of the second baby is different from the blood by the Rh of the second baby is different from the blood of the mother, this will lead to the autoantibody that are produced in the blood of the mother from the first baby will transfer and will attack the red blood cell, and it will lead to the severe hemolysis, which lead to the erythroblastosis fetalis. Therefore, this mother, if she is Rh negative and the baby is Rh positive, should be given anti-D within 72 hours post delivery in order to prevent the production of the autoantibody against the fetal red blood cell. Autoantibody might be idiopathic, maybe drug associated, certain drugs that when given to the when it's taken by the person, it might be induce the production of the antibody, or in the cases of the SLE, systemic lupus erythematosus, which is that autoimmune disease that the patient has its autoimmune antibody against its own tissue and organ. Sometimes mechanical trauma to red blood cell, as in the microangiopathic hemotic anemia, thrombotic thrombocytopenia purpura, or GIC, or in the cases of the infection cases of malaria. When there is impairment in the red blood cell production, there is disturbances in the proliferation and maturation of stem cell. In case of a pure red cell aplasia or in the aplastic anemia, there is cessation of the production of the bone marrow. There is no cells are produced by the bone marrow. This might be due to, as most of the cases, it is idiopathic, and some of the cases related to the intake of drugs, as example, or certain associated infection. Anemia of renal failure, anemia of endocrine disorders. Sometimes there is disturbance in the proliferation and maturation of the erythroblast, in which case, when there is defective DNA synthesis, in the case of the megaloblastic anemia, in the case of vitamin B12 deficiency or folic acid deficiency, anemia and of renal failure, because there is erythropoietin deficiency, which is very important to stimulate the production of the red blood cell, or the anemia of a chronic disease. When there is defective in the hemoglobin synthesis, it's either defective in the heme synthesis, as in the iron deficiency anemia, which is seen in the poor iron intake, poor food in the poor communities. Also can be seen in the certain ulcer, and when there's disease in the GI tract, as in the peptic ulcer, bleeding ulcer, or the tumor in the colon or tumor in the stomach. All of these might lead to the iron deficiency anemia. As well, the other cause of heme synthesis defective in the heme synthesis and sideroblastic anemia. The other defect might be due to the globin, as in the thalassemia, or might be due to the marrow replacement because of the hematopoietic tumor, as in the leukemia or myelodysplastic syndrome, marrow infiltrated by the metastatic tumors, or by granulomatous disease, as in the tuberculosis. It is called myelocytic anemia. What is the myelocytic anemia? It is the anemia which is characterized by normocytic normochromic that occurs when normal bone marrow is infiltrated and replaced by the non-hematopoietic or abnormal cell. Might be due to the tumor, tuberculosis, or any other granulomatous disorder, or might be due to the lipid storage disease. Anemia of the blood loss. We have blood loss, either acute blood loss or there is chronic blood loss. So, when there is acute blood loss, when the blood loss exceeding 20% of the blood volume, so the patient have hypovolemic shock rather than anemia, because there is no time. The anemia need time to develop. If the patient survive after losing of this 20%, there is hemodilution begins after 2 to 3 days. The anemia, the type of the anemia, and the anemia of the chronic blood loss, it is normochromic normocytic type. Later, within 5 to 7 days, there is erythropoietin production, which lead to the stimulation of production of RBC from bone marrow. This is manifested. How it manifested? How we know that the bone marrow is produced through producing RBC in the red blood cells due to the stimulation by the erythropoietin? Increase in the count of reticulocytes in the peripheral blood. We count the number of reticulocytes, it would be a higher number that the patient, that means the patient, there is an increased production of the bone marrow because of the stimulated by erythropoietin secretion. The other type of blood loss is a chronic blood loss. Iron stores are gradually depleted, gradually result in iron deficiency anemia, in which case, in the case of the peptic ulcer, bleeding peptic ulcer patient, doesn't realize that he has a bleeding loss unless he has fatigue, pallor, easy fatigability, fatigue on exertion, tiredness, loss of concentration when he is studying, pallor, palpitation, many symptoms. The patient doesn't realize that he has something wrong in that blood unless go to the, and he noticed that his stool is black tarry stool. So that means there is occult internal bleeding. It is a peptic ulcer, most probably peptic ulcer. Should go to the GIT doctor, should go to the GIT doctor in order to diagnose the patient, and in the endoscopy he will see by endoscopic examination he will see there's a bleeding ulcer. This is a gradual loss of the blood. It is a chronic blood loss. In other chronic blood loss in patient with has a female patient with around the menopause, perimenopausal, has menorrhagia, irregular bleeding, spouting of the blood irregular, so she has sometime there during her period, menorrhagia. All of these are included in the chronic blood loss. Now we are coming to the hemolytic anemia, تكسر كريات الدم الحمر. Normally, red blood cell lifespan is 120 days. The anemia associated with accelerated increase destruction of RBC is called hemolytic anemia. There are many types of many causes that lead to the hemolytic anemia. As we said, there are certain congenital or inherited hereditary types, and the other is acquired. The hemolytic anemia, as in sickle cell anemia, the RBC life is only 20 days. In sickle cell anemia, 20 days instead of 120. Red blood cell destruction can be caused either to inherit, as we said, intracorpuscular red cell defect, or there is external extracorpuscular factor, or acquired. The general features of all hemolytic anemias include decrease in the red blood cell lifespan, compensatory increase in the erythropoiesis, retention of red blood cell destruction product, as example the iron and bilirubin. In severe hemolytic anemia, extramedullary hematopoiesis develop in the spleen, liver, and node. Red blood cell destruction can be intravascular compartment called intravascular hemolysis, which can result from the mechanical force, that to say it is from the trauma. As example, when there is defective in the heart valve, or when there is valve processes or biochemical, physical agent that damage to the red blood cell membrane, sometimes as in the fixation of complement or exposure to the Clostridium deficient toxins, or in case of heat, or in case of disseminated intravascular coagulopathy. Intravascular hemolysis is seen in paroxysmal nocturnal hemoglobinuria, in which there is that the damage to the red blood cell fixation of the complement. This is seen in paroxysmal nocturnal hemoglobinuria. G6PD, in which there is deficiency of the certain enzymes. Immune hemolytic anemia. There are many causes that including immune hemolytic anemia, microangiopathic hemolytic anemia, and malaria. This is a scheme that showing intravascular hemolysis. In the next slide, we will discuss what will happening in the intravascular hemolysis. This is RBCs. When the destruction of the RBCs, the hemoglobin will released from this red blood cells. The hemoglobin, tetramer hemoglobin, most of the hemoglobin should be combined with the haptoglobin, which is the protein that are synthesized in the liver. There are certain level of the haptoglobin in the blood. When there's the hemolysis is more than normal in the blood, the destruction of the red blood cell is more than normal, so the haptoglobin will reduce, will decrease. What will happen to it? It will lead to the free hemoglobin. Free hemoglobin where? In the blood. Some of this free hemoglobin, it will be oxidized and form methemoglobin. So all of this scheme, we will discuss it thoroughly in the next slide. Another scheme of intravascular hemolysis and extravascular hemolysis. We will discuss it in detail in the next few slides. This is intravascular. Here, briefly, intravascular destruction of red blood cell will release hemoglobin, free hemoglobin. Free hemoglobin will combine with the haptoglobin, which is the protein that's synthesized in the liver. This is complex, and then this is taken up by the macrophage and then to the liver and spleen, the same way of the extravascular hemolysis, the same mechanism taken by a liver and spleen. Here the remaining of the hemoglobin become oxidized into the methemoglobin. Methemoglobin also dissociate into the heme and dissociate into the methemoglobin dissociate also into the heme, and some of the heme that combined with hemopexin complex and get the same way of the hemoglobin haptoglobin complex as it is taken up by the macrophages and then to the liver and spleen and the same pathway, while here in the heme and the albumin and go to the circulation and excreted into the part of it, the remaining part of the heme will become as much hemoglobin that will release in the proximal tubule in the kidney. So long standing of the hemoglobin urea, it will lead to the damage to the proximal renal tubules, and it will affect the reabsorption capacity or the ability of the proximal cell of the proximal tubule. So the cells of the proximal tubule of the kidney can no longer to reabsorb the molecules. So patient might have hyperamino acid urea and loss of the potassium and dehydration, and then may lead to the chronic renal failure. Now we are coming to discuss the intravascular hemolysis mechanism. When the serum concentration of free hemoglobin is within normal or within the physiologic range of haptoglobin, so the harmful effects of the free hemoglobin are prevented because of the haptoglobin, because the haptoglobin will be combined with the hemoglobin and cause free hemoglobin haptoglobin complex. While in the hyperhemolytic condition or in chronic hemolysis, haptoglobin is depleted because it will be consumed by hemoglobin. So the remaining free hemoglobin that readily, easily distribute to the tissue, it exposed to the oxidative condition. Thus, some of the ferrous heme, the oxygen binding component of the hemoglobin, of the free hemoglobin, are oxidized. What will make it? Will become methemoglobin, ferric globin. In such a condition, heme along with the globin chain can be released from the further oxidation of methemoglobin. When there is free heme, can then accelerate tissue damage by enhancing or by promoting peroxidative reaction, and subsequently it will activate the inflammatory cascade. At this time, hemopexin. What is the hemopexin? Hemopexin is another plasma glycoprotein, which come to bind with the heme. It is a privilege of the high heme affinity forming a complex of the hemopexin, which is non-toxic, travel together to the receptor in the hepatocyte macrophage within the spleen, liver, and bone marrow. We have to note that free hemoglobin haptoglobin complex is taken by hepatocyte and to lesser extent by the macrophage. Therefore, this complex will undergo metabolic mechanism like extravascular hemolysis. If the binding capacity of the haptoglobin and hemopexin are saturated, so the free hemoglobin in the plasma will be oxidized to the methemoglobin eventually, and will be further dissociated into the free hemo and others. In this stage, the free heme, when it will where it will bind, it will be bound to the albumin, and it form methane albumin. But the remaining of unbound methemoglobin, it filtered into the primary urine and reabsorbed in the proximal tubule of the kidney. In the proximal tubule, the iron is extracted and stored as hemosiderin. Long-term hemoglobinuria associated with substantial deposition of hemosiderin in proximal tubule. There's excessive accumulation of the hemosiderin in the proximal tubule, in addition to the Fanconi syndrome. What is meaning of the Fanconi syndrome? When there's excessive accumulation of the hemosiderin in the proximal tubule and there's excessive long-term hemoglobinuria, it will lead to the damaging of renal reabsorption capacity of the small molecule, which give rise to what? To the hyperaminoaciduria, because the proximal tubule no longer can reabsorb. So aminoaciduria in the urine, glycosuria, hyperphosphaturia, bicarbonate, and dehydration, and then finally, eventually, it will lead to chronic failure. This type of the hemolysis, intravascular hemolysis, characterized mainly by hemoglobinemia, increased amount of the hemoglobin in the blood, hemoglobinuria, hemoglobin in the urine, hemosiderin in the urine, excess hemoglobin destruction lead to the unconjugated hyperbilirubinemia and jaundice, yellow discoloration of the skin and sclera, and in massive hemolysis, acute tuberous necrosis of the kidney develop, and subsequently it will lead to the, or eventually lead to the chronic renal failure. The haptoglobin, as we said, which is a protein that is synthesized by the liver, it will be, when it's bind to the free hemoglobin, is reduced and sometimes it is absent in the plasma. In addition, the lactate dehydrogenase enzyme is increased. This enzyme is present in the cardiac muscle as well in the red blood cell. So it is increased when it is released from the lyzed red blood. This is a test tube which contain urine. This is a urine, but this is the urine in patient with hemolytic anemia in which there is hemoglobinuria. There is hemoglobin in the urine. Blood look like blood because it's contain large amount of the hemoglobin, or the hemoglobin level or in this urine is very high. Extravascular hemolysis. This occurs where it occurs within the cells of a mononuclear phagocytes of reticuloendothelial system. This is more common mode of red blood cell destruction, would take place in the phagocytic cell of the liver and spleen. Most common in which condition it is happened, or it occurs in the hereditary spherocytosis, which will be discussed in the next slides, and in the sickle cell anemia. In this type of hemolysis, no hemoglobinemia or hemoglobinuria seen. With prolonged hemolysis, This type of extravascular hemolysis, if prolonged, it will lead to the splenomegaly, jaundice, formation of the bilirubin-rich gallstone, haptoglobin is always decreased, and secondary hemochromatosis due to the high level of the iron which is extracted from the heme due to the destruction of a red blood cell. This is the normal scheme of extravascular hemolysis. It shows that how the extravascular hemolysis take place in the body. The diagnosis of the hemolysis. Hemolysis is suspected in patient with anemia and reticulocytosis. When patient has anemia and increase the number of the reticulocyte above the normal level of it in the blood, so we suspect that patient have hemolysis. So we will do peripheral smear, should be examined, peripheral blood film, serum bilirubin, blood biochemistry, lactate dehydrogenase, haptoglobin in the blood, ALT, which is the liver enzyme, and also we will do Coombs test. We have direct and indirect Coombs test or hemoglobinopathy screen, which is hemoglobin electrophoresis. The peripheral blood film will see that reticulocyte count are the most important test to diagnose hemolysis because in the peripheral blood film we will see nucleated red blood cell as well reticulocyte in the blood in the peripheral blood, and the reticulocyte count will be done, which is the most important test to diagnose and confirm hemolysis. The other laboratory tests that can be help to identify the cause of the hemolysis include quantitative hemoglobin electrophoresis, especially for sickle cell anemia and thalassemia and other hemoglobinopathies, RBC enzymes assay as in G6PD, flow cytometry, cold agglutinin, osmotic fragility. All these tests is very important in order to identify the cause of the hemolysis, in order to know the mode of the treatment for each one, and to identify which type of hemolytic anemia we have, and we have to determine whether the hemolytic anemia is extravascular or intravascular. All of these should be done in order to reach proper diagnosis. This is a picture or photograph of the patient with jaundice, yellow discoloration of the sclera, which is seen also in patient with hemolysis. Also, in hemolytic anemia, increase the incidence of the pigmented or bilirubin gallstones. Hereditary spherocytosis. This type of a blood disease, it is inherited. It is due to the autosomal dominant trait defect in the red blood cell membrane. In about 25% of the cases, severe autosomal recessive. The defect usually renders the red blood cell to be spherical, spherocyte, become less deformable and liable for splenic, sequestration and destruction by phagocytic cells. The pathogenesis in hereditary spherocytosis is due that defect is within one group of protein that form a supporting skeleton on the intracellular face of red cell membrane. The major protein is spectrin, which is linked to the cell membrane at 2 points. Here how the spectrin linked to the cell membrane. First through the ankyrin and band 2 to intrinsic membrane protein and band 3, and through band 4.1 to intrinsic membrane protein glycophorin. We will see this in details in the next picture. Both vertical and horizontal spectrin interaction, this serves to stabilize the shape and flexibility of the cell. When there is a mutation, which mostly involve the ankyrin or band 3 or spectrin, so The most common feature of the all hereditary spherocytosis mutation is that they weaken the vertical interaction between the membrane skeleton and the intrinsic membrane. This is the pathogenesis of spherocytes. This is banditry and spectrin and ankyrin. And when there is a defect, when there is hereditary spherocytosis, it might be due to the defect in the spectrin, defect in the or in bandit3 or in the ankyrin, which lead to the interaction would be defect in the interaction, which lead to the red blood cell. This is a biconcave shaped red blood cell. Become, look at here, look at this is a blebbing till become spherocyte. The spherocyte become less deformable and liable to be sequestrated and engulfed by the splenic macrophage and then to be destroyed. In all type of hereditary spherocytosis, the red blood cell have reduced in the membrane stability, and consequently it will lead to the loss of the fragments in the form of a blebs, become detached from the wall, from the membrane. Then after their release into the periphery, while retaining most of their volume. So as a result of this, the ratio of the surface area to the volume of this spherocyte cell decrease till the cell becomes spherical. So at which the point no further membrane loss is possible. The spleen play a very important and major role in destroying the spheroid or spherical red blood cell because they cannot undergo an extreme degree of deformation to pass through splenic sinusoids, so cannot deformed because cannot have the flexibility in order to get rid of this of the splenic macrophages. So when they will be sequestrated and phagocyted by the splenic macrophage. The structural defect of red blood cell, it lead to the reduction in the deformity and formation of spherocyte, which this spherocyte would be trapped by the splenic sinusoid and then phagocytosed by the splenic macrophages. In this stage, it will lead to the extravascular hemolysis. Extravascular hemolysis means the hemolysis that take place in the liver or in the spleen, not inside the blood vessels, which is the characteristic of the intravascular hemolysis. Here in the extravascular hemolysis, it is characteristic feature of it is characterized by the anemia, increase in the reticulocyte count, and splenomegaly. Morphology, the red blood cell lack the central zone of the pallor. They are not biconcave, they look spherical. With the peripheral reticulocytosis, the spleen is enlarged, heavy weighing between 500 and 1000 grams or more. Other features of hemolysis including cholelithiasis, which is the formation of the gallstone, and the osmotic fragility of the red blood cell is increased. What does that mean? That means that red blood cells are easily hemolyzed when put or kept in the hypotonic saline solution. This test consisting of exposing the red blood cell to varying strength of hypotonic solution and comparing to the normal and measure the degree of hemolysis colorimetrically at the temperature of room. This is the fragility test, which is a diagnostic of hereditary spherocytosis. When there is red blood cell membrane abnormality, the first row is normal when putting in the hypotonic solution, while the lower one showing hereditary spherocytosis because hemolyzed when put it in hypotonic solution. This is a blood film of patient with a hereditary spherocytosis. This is the normal. This is biconcave. Look at here. It's a biconcave. I don't know what is. This highlighter. Okay. This is the polychromasia, which is Polychromasia, about that the RBC is not fully mature because of destruction. This is because of the lifespan of the spherocyte is less than normal by concave. Here is the spherocyte. Look at spherocyte. It's like spherical. It's like a ball. Like a ball. Not like the normal. Loss of the deformability that his spherocyte cannot be deformed in order to get away from the sinusoid, and then it will be trapped by the macrophage. This is a reticulocyte. The peripheral blood formed by crystal violet, which stain that used to show reticulocyte, it is crystal violet. It is immature red blood cell. Why we see immature? Because it's hemolysis, because there is destruction of red blood cell. So the bone marrow tried to produce more red blood cell in order to compensate this the destruction and to replace the normal. So we have seen, we will see the reticulocyte. Look at here, and this is the dot-like violet dot-like cells with the dot-like distribution distributed inside the red blood cell. It is reticulocyte, which is seen in the hereditary spherocytosis. What's here? The blood film in the hereditary spherocytosis. This is another blood film. Good. This is spherocyte. This is spherocyte also. This is platelet, aggregation of platelet. This is neutrophil. This is maybe macrophage. Oh, no, that's not macrophage. Monocyte. Yeah, it's the monocyte. When get into the tissue, become macrophage. But in the blood, it is monocyte, called monocyte. This is a spherocyte. Look at here. Look at even the distribution of the hemoglobin inside the spherocyte is different from the normal. Let's see if there's any normal looking. This is a central pallor present, but here there's lack of the pallor, central pallor. Lack. Look at here. This is also a blood film showing reticulocyte. This is a reticulocyte, which is immature red blood cells that are produced in the bone marrow and then released into the blood, peripheral blood, when this is usually seen in hemolytic anemia. What is reticulocyte? Reticulocytes are immature red blood cells. In the process of erythropoiesis, red blood cell formation, reticulocytes develop and mature in the bone marrow, and then it circulates for about a day in the bloodstream before developing into mature red blood cell. Like mature red blood cell, when there is increase in the reticulocyte, means there is increased destruction of the red blood cell, there is increased production and formation of red blood cell in the bone marrow, so there is increase in the number of this reticulocyte in the peripheral blood. It is like mature red blood cell. It do not have cell nucleus because they have mesh-like network of ribosomal RNA, dot-like. So it appears as dot-like. This is a network of ribosomal RNA which can be visualized or can be visible by microscope when we use or stain the blood film with a certain stain such as a new methylene blue and Romanesky stain. The clinical course of the patient with hereditary spherocytosis characterized by the anemia, splenomegaly, and jaundice. Jaundice means yaraqan, increase the bilirubin in the blood. Anemia, decrease in the hemoglobin, and splenomegaly is enlargement of the spleen. The severity of the anemia is variable, but is commonly moderate in severity. Generally, the course of the disease is stable, but sometimes there is aplastic crisis. What is the meaning of the aplastic crisis? There is transient cessation of red blood cell production. What does that mean? That means that patient infection, there is infection of the bone marrow, erythroblast, made particularly normoblast by parovirus B19, which lead to the cessation of red blood cell production. Let us erase what we... Okay. This is a microscopical view of bone marrow. This is the bone marrow, which showing parovirus B19 infection of normoblast. This is a parovirus inclusion in the normoblast. Here, and these are the cells that including the parovirus infection B19. By immunostaining for parovirus 19 in bone marrow, we can see the infected normoblast stain brown. This is because it is infected by parovirus. So infected normoblast stain with the brown because they are infected with the parovirus 19. The treatment of the patient with hereditary spherocytosis. First, splenectomy. Splenectomy is beneficial for those who are symptomatic because it is a major site of red blood cell destruction. So there is no more spleen to destroy the red blood cell. Following splenectomy, what will we see? Anemia will be corrected because there is no spleen to destroy it, the red blood cells. But spherocyte still persists in the peripheral blood because the disease is still present in the patient and the problem is still in the blood. So the spherocytes persist. Appearance of the Howell-Dolly bodies. There is Howell-Dolly body is a nuclear DNA remnant which is normally removed by the spleen. It is seen in the peripheral blood. This is seen in patients with splenectomy. Howell-Dolly body, which is a nuclear DNA remnant that is seen or that is normally removed by spleen. Those patients with the splenectomy, because the treatment of choice for such a patient, they have to get vaccination against pneumococcus and Haemophilus influenza. It is a must. Why? Because when there is no spleen, those patients will be more susceptible to get infection by the more pathogenic microorganism, including pneumococcus and H. influenza. So those patients should have or should get vaccine. In addition, during a plastic crisis, if the patient infected with the parovirus 19, we can give supportive blood transfusion. This is a spleen of the patient with a spherocytosis. This huge splenomegaly, one of the causes of the huge splenomegaly or very severe splenomegaly enlargement, excessive enlargement of the spleen, is the hereditary spherocytosis. The treatment of choice for such a patient, removal of the spleen. Blood film showing this is a Howell-Dolly body, which is a remnant. Look at these dots are the remnant of the nuclear DNA that is seen in the patient following splenectomy. Here we are coming to the sickle cell disease, hemoglobinopathy, one of the hemoglobinopathy that inherited type of hemoglobinopathy. Normal hemoglobin consisting of 4 globin chains but comprising two pairs of similar chain, each with its own heme group. Normally, the hemoglobin in the adult composed of 96% of hemoglobin A, which is 2 alpha and 2 beta, 3% A2, 2 alpha and 2 delta, 1% of hemoglobin F, 2 alpha and 2 gamma. Sickle cell anemia is a form of hemolytic anemia that caused by point mutation at the 6th position of beta globin chain, which lead to substitution of valine for glutamic acid residue. It is inherited by its autosomal recessive inheritance. Sickle cell disease arises when two abnormal beta genes are present in homozygote, represented as hemoglobin S, leading to production of 96% of hemoglobin S, 2 alpha and 2 beta. S mean there is substitution of valine residue for glutamic acid in this beta chain in RBCs. Should be 96% of the hemoglobin is hemoglobin S, and the remaining hemoglobin A2 about 3%, hemoglobin F about 1% in the patient blood. While the trait which arises in the heterozygote, when less than half, about 43% of RBC have hemoglobin S, and the remainder is hemoglobin A, which show the rate of polymerization and sickling, so here the anemia is a bit mild. In a trait, the hemoglobin as follows: hemoglobin S constitute 43% of the hemoglobin, A 55%, remaining A2 2%. The incidence of sickle cell anemia is the most common familial hemolytic anemia in the world. It's more common among African and Asian population. Actually, more common in Basra, in Iraq, and also in Kuwait. In USA, it is constituted about 8% of blacks heterozygous for hemoglobin S, and 1 out of 600 blacks have sickle cell anemia. In Africa, where the malaria is endemic, the frequency of the gene about 30%. But it was found that hemoglobin S has a protective effect. The patient that has malaria and they have 30% hemoglobin S, they found that the malaria, this hemoglobin S act as a protection against Plasmodium falciparum malaria infection. The reason behind this fact, they suggest or they propose that Plasmodium falciparum merozoite bind by parasite lectin-like molecule in the sialic acid residue on a glycophorin molecule on RBC's membrane. Possibly due to the failure of formation of the positive charge parasite-encoded protein in RBC's surface membrane, this facilitates the adhesion of malarial parasite to RBCs. Might be this is the cause that render the patient that has hemoglobin S has a protective effect against Plasmodium falciparum. Pathogenesis. When deoxygenated hemoglobin S molecule undergo aggregation and polymerization, and with continued deoxygenation, this aggregated hemoglobin S assemble تتجمع into long needle-like fibers within the red blood cell, which give rise or produce distorted red blood cell holly leaf shape تشبه الهلال or the leaf. However, the sickling, in addition to the hypoxia that induces sickling, there are other factors that also can induce sickling, as in the case of the dehydration, acidosis, and infection. Dehydration, it increases the concentration of the hemoglobin that facilitate sickling. Sickling of red blood cell initially is reversible. With reoxygenated of the hemoglobin S depolymerize, then the cell shape return to normal. While when there's repeated episodes of sickling, this will lead to the damage to the membrane, and the cell accumulate calcium, lose potassium and water, then become irreversibly sickled. Even if we oxygenate or reoxygenate, this cell will retain its abnormal shape, and there is no benefit of reoxygenation. Three most important variables that influence the sickling of RBCs. First, when there is presence of hemoglobin other than hemoglobin S. Hemoglobin A, in heterozygote hemoglobin S, there is hemoglobin A, as we said, there's constitute when hemoglobin S approximately constitute about 43%. The remainder is hemoglobin A, which constitute about 55%, which react weakly with the oxygenated hemoglobin S. So the presence of hemoglobin A, it will slow the rate of polymerization. This is a logic, because the constituent of the blood of hemoglobin, two types of the hemoglobin, 43% constitute by hemoglobin S, while the remainder is hemoglobin A. So this is lead slowing the rate of the polymerization التكتلات والتحولات. So sickling of RBC and the sickling, this result in mild anemia. What about hemoglobin C? It's another mutant of the beta globin, in which lysine residue instead of normal glutamic acid at position 6. This is the type of the hemoglobin C. And when in beta globin chain, there is lysine residue instead of normal glutamic acid position. It's fairly common in USA. The incidence about 1 per 1,250. The newborn baby are double heterozygote. They inherited hemoglobin S from one parent, while hemoglobin C from the other parent. So the hemoglobin become hemoglobin S and C. There is percentage. It's about 1 per 1,250. So there's a number. The other parents. So when this is heterozygote, inherit both hemoglobin S from one parent and C from other parent, the hemoglobin became hemoglobin C, SC. Hemoglobin C has a greater tendency to aggregate with the S than hemoglobin A. This is called hemoglobin SC disease, and the patient tend to be more symptomatic but have mild anemia. But it aggregates more with hemoglobin C than hemoglobin A. Regarding hemoglobin F, which is interact more weakly with S. Therefore, newborn with the hemoglobin sickle cell anemia and do not manifest the disease when he has hemoglobin F till 6 months of age, because hemoglobin F gradually fall to adult level and is not react with hemoglobin S. The concentration of the hemoglobin S in the cell. In hemozygote, the red blood cell dehydration increase the concentration of hemoglobin S, which in this case, when there is dehydration, it will facilitate the sickling during the oxygenation. And this then, it will trigger the occlusion of small blood vessels. So when there is dehydration, this leads to the increased hemoglobin concentration, which lead to the sickling during the oxygenation. And this leads to the occlusion of the blood vessels, instead, occluded by sickling RBCs. This is in the homozygote. While in the heterozygote, or with sickle cell trait, low concentration of the hemoglobin S, because in the homozygote, hemoglobin S constitutes the majority of the hemoglobin constituent, while here it's constitute only 42%. So it's contribute to the lack of sickling and mild symptomatic anemia. At the same time, when there is coexistence of alpha thalassemia, yes, sometimes there's coexistence of two hemoglobinopathies. Of course, there's two. It will reduce the hemoglobin S concentration because there's other hemoglobin that contributing in the hemoglobin, in total hemoglobin concentration. So the severity of sickling will become less. And this is attributed to the low MCHC, mean corpuscular hemoglobin concentration. That to say the hemoglobin concentration in the RBC in the thalassemia reduce the polymerization of hemoglobin S. Other factor that affect the length of the time that RBC are exposed to low oxygen tension. Normal transit time of RBC to pass through the capillary not sufficient for significant aggregation of deoxygenated hemoglobin S to occur. Normally, the time when the red blood cell pass through the capillaries are not sufficient, not enough for significant aggregation of deoxygenated hemoglobin S to occur. So, sickling is confined to the microvascular bed. Why? Because of the blood flow is sluggish. This is normally seen in bone marrow, in spleen, sometimes in the kidney. Those are prominently affected by sickle cell disease. Other factor, the inflammation. All of us, we know when there is inflammation at any site, what will lead? The inflammation, the vascular changes in the inflammation. This will lead to the slowing of the blood flow. As a result of the adhesion of the white blood cell, you remember immigration and first there's margination and adhesion, and then all of this adhesion and the consequence of the vascular changes in the inflammation with the slowing of the blood flow result of adhesion of white blood cell, red blood cell to endothelium. This will lead to the increase in the transit time of RBC, making clinically when there is slowing, so it's easy for red blood cell to cause or to form sickling. So in the inflammation, there is increased the incidence or the rate of sickling. This is a diagrammatic view of intravascular sickling of red blood cell at the site of hypoxia. Look at sickles, leaf-like shape of red blood cell. This is sickling. This is the typical picture of the sickled RBCs. This is a blood vessel. This is a normal red blood cells. Here we are coming to the diagrammatic view of mechanism of sickling and hemolysis in sickle cell disease. This is a various picture that showing here what is the hemoglobin S. There is a glutamic acid valine in the, by the way, there is a point mutation. This is a substitution of valine for glutamic acid here. تبادل يصير. Hemoglobin S, oxygenated blood, normal. When there is deoxygenated, it is polymerization, and polymerization, it will in the spleen or in the microvasculature, in the bone marrow, or in the organs, that when there is slowing of the blood inside it, more sickling take place. And also there is other factor when there's macrovascular occlusions, and here increase in the RBC transit time in the inflamed tissue. So this is a description of what we have discussed in the previous. There are two major consequences stem from the sickling of red blood cells: extravascular hemolysis and microvascular occlusion. When there is repeated episodes of deoxygenation, it will lead to the damage to the membrane and dehydration of red blood cells that become rigid and recognized and removed by the phagocytic cells, which lead to the extravascular hemolysis. The chronic hemolysis is associated with reticulocytosis. Actually, it is marked reticulocytosis. And in addition to the hyperbilirubinemia, because of this is hemolysis, and gallstone formation. The other consequence is microvascular occlusion. When there is sickling of red blood cells, it tends to occur in the area when the blood flow is sluggish and slow, as we said, in bone marrow, spleen. Thus, it will produce microvascular occlusion. Actually, it is widespread microvascular occlusion, which lead to the ischemic changes and subsequently to the infarction. What will we see in the bone marrow of the patient? We will see hyperplastic bone marrow. Why? Because it is compensatory hyperplasia of erythroid progenitor. This compensation, in order to compensate the destruction or the hemolysis of the red blood cells, so the bone marrow try to compensate the loss of the blood or the anemia. At the same time, those patients with hemolytic anemia showing expansion of the bone marrow. What does that mean? That means there is an expansion of the bone marrow because of the increased production of the because of the hyperplasia, increased production of the bone marrow to compensate the anemia and the resection of the RBCs, lead to the bone resorption and secondary bone formation. So the cheek of those patients become more prominent and changes in the skull. Those patients that have this feature more commonly seen in sickle cell anemia and in the thalassemia. Blood film showing variation, so it is called anisopoikilocytosis. Anisocytosis, change in the size of red blood cells, while variation in the shape of cells called poikilocytosis with target cells. What is the target cell? RBC, the hemoglobin collect in the center. Why? Because result from the increase in the surface area to the volume, which allow the hemoglobin to collect in the center. Also, at the same time, in the peripheral blood, we see sickle cells and spindle cell. تشبه الهلال. We will see the sickle cell now in the next slide. And of course, because of their production of the bone marrow, increased production of the bone marrow and hyperplasia, we will see find nucleated red blood cell in the peripheral blood. The spleen, large, heavy, and about 500 grams in weight. Red pulp widening, and sometimes there is autosplenectomy. This is one of the pictures that's showing peripheral blood film. This is a nucleated red blood cell. Look at it. Nucleated red blood cells. This is a sickle cell. This is a target cell. Look at the hemoglobin is collected in the center. This is also blood film in the sickle cell anemia. Sickle cell, holly leaf appearance of the red blood cell. Leaf-like structure. This is a target cell. Maybe this is a monocyte, or there's neutrophil, but I think it is not typical neutrophil. It's not a neutrophil. Maybe segmented. Maybe I don't know. It's not clear. Anyway, ignore it. This is a sickle. Focus on this sickle cell, leaf-like structure, and this is a target cell. This is also sickle cell, leaf-like, شبه الهلال. This is a neutrophil, and this is a normal RBCs. Clinical features. Homozygous sickle cell disease usually become apparent after 6 months of life. Why after the 6 months of life? Because in the first 6 months it is protected by hemoglobin F. This is a fact. From the onset, the process runs as an unremitting course because it is homozygous. Most of the hemoglobin the majority of the hemoglobin that constitute in the blood is a hemoglobin S. So the patient run unremitting course. Severe anemia, chest pain, shortness of breath because of the sickling, red blood cell hemolysis, hyperbilirubinemia, jaundice, bile pigment stone, hematocrit PCV 18 to 30%. Normally is between 35% to 45%. So this is anemia. Patient has anemia with widespread microvascular occlusion because aggregation of sickling red blood cell in the blood vessels, which lead to the ischemic changes in the tissue, in the organ. Different organs might be affected, like bone, liver, heart, spleen, brain, with severe pain because of the sickling, because of the occlusion of the blood vessel, ischemic changes, pain in the bone and in the organ that is affected or there's occluded inside, and it might lead to the infarction and necrosis. There is swelling of the hand and feet. It is called dactylitis. This is also due to the vaso-occlusive infarction in the bone, even in the infants. This is usually seen in homozygous sickle cell. This is a photographic appearance of the swollen hands, dactylitis. Look at this swollen because of the occlusion of the blood vessels in the bone. My God. And distended abdomen also because of the hepatosplenomegaly. Look at the color of the skin of the patient, because we say that sickle cell is more in the black race than in other race. Complication: acute chest syndrome. It is triggered, induced, provoked by pulmonary infection, fat embolism from necrotic marrow that's secondarily involving the lung. When the blood flow in the inflamed ischemic lung, it becomes, of course, sluggish, spleen-like, leading to the sickling within the hypoxic pulmonary beds, which lead or create a vicious circle of worsening pulmonary and systemic hypoxemia, sickling, and vaso-occlusion. This is acute chest syndrome, which is triggered by the pulmonary infection and fat embolism from the necrotic bone marrow. Central nervous system stroke also, because of sickling, occlusion, infarction, ischemia, infarction. It might be manifested by the seizures, convulsion, and stroke, as well as septicemia and infective meningitis. Both acute chest syndrome and central nervous system stroke are the two leading causes of ischemia-related death. Aplastic crises represent sudden but usually temporary cessation of erythropoiesis. يتوقف عمل البون marrow من إنتاج red blood cells. It's an hereditary spherocytosis that triggered by parvovirus B19 infection of erythroblast. The same infection, parvovirus infection, cause aplastic crisis in sickle cell anemia. It is severe, however, it is self-limited. Asplenic making them susceptible the infection in case of sickle cell anemia. Asplenic make them susceptible because there's occlusion of the spleen and infarction and repeated this lead to the asplenic. This patient have very small spleen, but it's non-functioning because by repeated occlusion, by repeated sickling, it will lead their patient is asplenic as he has no spleen. Make them susceptible to infection by pneumococcal or Haemophilus influenza encapsulated bacteria. For unknown reason, those patients with sickle cell anemia are at high risk of Salmonella osteomyelitis. Hyposplenism and autosplenism. In adults, the basis for hyposplenism, as I told you, is an auto-infarction. In early childhood, splenic enlargement, because there is large spleen in patients with a sickle cell anemia and congestion, caused by trapping of sickle cell, which interfere with the bacterial sequestration and culling, so the children are more susceptible to fatal septicemia. Extramedullary hematopoiesis can be seen in the spleen and liver. In children, the spleen is commonly enlarged, which weigh 500 grams and showing congestion of the red bulb. Vascular occlusion and diastasis, it will lead to the thrombosis and infarction when continued scarring develop, which lead to progressive shrinkage of the spleen. This is called autosplenectomy. Because of the vascular occlusion, leg ulcers are also seen in patients with sickle cell anemia. The compensatory hyperplasia of erythroid progenitor in the marrow lead to the resorption and secondary new bone formation, which result in the prominence of the cheekbone. This gives appearance of chipmunks. We will see this picture later in this slides, as well as the change in the skull. The changes in the skull by X-ray, when we do skull X-ray, it is called look like crew cut or hair on end appearance. Microscopical view of the extramedullary hematopoiesis. hematopoiesis. This is extramedullary hematopoiesis. We see all the series of the red blood cell and all the progenitor cell. This is a megakaryocyte. Look at this is a large cell multinucleated. This is a megakaryocyte, and in addition to the myeloid series and the red blood cells progenitors. Extramedullary hematopoiesis. What is extramedullary hematopoiesis? It refers to hematopoiesis that occurring outside the medulla of the bone marrow. The formation, development of the blood cell that normally occurs inside the medulla of the bone marrow. In such a case, it's no longer in the bone marrow, it occurs outside of the medulla of bone. It might be physiologic as in the case of embryonic and fetal development in the embryo. Pathologic might be. This can occur during adulthood when the physiologic hematopoiesis cannot work properly in the bone marrow. So the hematopoietic stem cell, the mother cell, have to migrate to other tissue in order to continue with the formation of the blood cell component, as example to the liver and spleen. Pathological condition of the extramedullary hematopoiesis might be caused by myelofibrosis, might be caused by thalassemia, might be caused by any extravascular hemolysis that might induce the extramedullary hematopoiesis to take place in the tissue other than bone marrow. This is a splenic infarct in patient with the sickle cell disease. You see the size of the spleen is already shrinkage due to the splenic infarct, continuous infarction and thrombosis. It will lead to the autosplenectomy. Multiple splenic infarct here, it will lead to the loss of the function, small non-functioning of the spleen, which is called autosplenectomy. Very small size of the. This is a skull X-ray, which showing heron and or crew cut appearance. Actually, this is a spot diagnosis of the patient with sickle cell disease because of the compensatory erythroid hyperplasia, which lead to the resorption of the bone and subsequently to the new bone formation. So the changes here appear as a hair on end or crew cut appearance. This picture is showing the photograph of a girl with sickle cell disease, which showing prominent cheekbones chipmunk-like. يشبه السنجاب، يعني شكل هذا rodent like animal يشبه السنجاب، يكون شكلهم ذولا patient اللي عندهم sickle cell disease because of the widening of the bone marrow because of the erythroid hyperplasia, which lead to the bone resorption and new bone formation, subsequently lead to prominent of the cheek. Look at here at the cheek. Can use the cheek, prominent of the cheek, and give the appearance of the chipmunk-like appearance. This is also another two pictures. This is skull X-ray, which is spot diagnosis. This is hair on cut appearance due to the also the same things. The cause of this, and this is a prominent cheek bone and hair on end appearance on the skull X-ray, and this is a face of the child suffering of sickle cell disease. This is a bone skull showing. What is the showing here in the skull? Look at it. Look at the thickness of the bone. It is expansion of red marrow arrow, which lead to the hair on end. This is, look at it, which result in X-ray. When on X-ray, it will show as hair on end appearance because of the expansion of red marrow because of the compensatory erythroid hyperplasia. Leg ulcer also. This is a leg ulcer can be seen in patients with sickle cell anemia. This is due to the repeated occlusion of the blood vessels by sickling. It might lead to the ulceration in the leg. This is another picture or another clinical presentation of the patient or the complication of the patient with sickle cell disease. In full-blown picture of sickle cell disease, the diagnosis of this picture, some irreversible sickle red cells can be seen in a peripheral blood smear, as well as target cells. So in peripheral blood film, we can see some of sickle cells which are irreversibly persist in the blood film, in addition to the target cells. This is seen in the full-blown picture of sickle cell disease. While in trait, no sickle cell can be seen, but can be induced in vitro by exposing red blood cell to the hypoxia, because the sickling in such a case, it only induced by the hypoxia or certain using of certain and taking of certain drugs that might induce sickling. So by using certain reducing agent like 2% sodium metabisulfite to be added to the fresh blood to induce sickling. In this case, we can see some of the sickle cells in patient we suspect that have sickle cell trait, of course, after doing hemoglobin electrophoresis, which is very important for the diagnosis, because hemoglobin electrophoresis is to prove and to confirm the diagnosis in patients suspected sickle cell disease. Prenatal diagnosis of sickle cell anemia can be performed by analysis of the DNA in fetal cell, which obtained from where? From amniocentesis. The fluid, amniotic fluid that aspirated from in utero can be analyzed, and we do the DNA analysis of the DNA in fetal cell, or we can take the biopsy of chorionic villi at the 10 to 12 weeks of gestation. This is a prenatal diagnosis of sickle cell anemia. The treatment of the patient with sickle cell disease, usually there is prophylactic treatment with penicillin to prevent pneumococcal infection, as this hemoglobinopathy is an inherited disease that it is autosomal recessive, so it's not easy to cure the patient completely unless we do bone marrow transplant, which is the curative mode of treatment. Otherwise, all the other treatments are prophylactic. So by prophylactic treatment with the penicillin, as we say, to prevent infection, pneumococcal infection, sometimes in certain situations, we use hydroxyurea therapy in order to inhibit DNA synthesis, in order to decrease the pain or reduce the pain in certain crises or lessen the anemia through the ISA by increasing the hemoglobin F synthesis, because the hemoglobin F, it will, and if it's increased in the red blood cell, it will decrease the incidence of sickling. And also hydroxyurea therapy that has anti-inflammatory effect through inhibition of white blood cell production and its metabolism to nitric oxide, which is potent vasodilator that and also inhibit to platelet aggregation. The bone marrow transplant is a curative. In sickles, only the curative mode of treatment in the sickle cell disease.